Hello, my name is Clara Wynn. I'm a second-year OBGYN resident at Wellstar Kennestone in Marietta, Georgia. And today I'm going to be presenting a case report that I prepared with two of my attending physicians, Dr. Condi and Dr. Koltopalli. This is the case of a patient who developed necrotizing pancreatitis as a complication of HELLP syndrome. I'll review some background information, details of the case, management and follow-up, and then a brief discussion and take-home points. So just for background information to start, HELLP syndrome is considered one of the most severe manifestations of preeclampsia. It is associated with significantly higher maternal morbidity and mortality. And even in the setting of pregnancies with preeclampsia, it is rare. So you see it in about 1 to 2% of pregnancies with preeclampsia. Pancreatitis is also considered rare in pregnancy and is most often associated with cholelithiasis, much like it is outside of pregnancy. So this case is the case of a 31-year-old patient. This was her first pregnancy. Prior to her admission for delivery and the development of necrotizing pancreatitis, her only significant past medical history was Hashimoto's hypothyroidism. She did have a history of Lyme disease and she had migraines. She was on medications for anxiety and reflux, as well as a prenatal vitamin. She presented to labor and delivery triage at 36 weeks and 3 days gestation with severe range blood pressures. So her blood pressures were systolics up in the 160s, diastolics up in the 110s, and severe epigastric and upper abdominal pain. Initial lab analysis did meet criteria for HELLP syndrome. She had an elevated creatinine, evidence of hemolysis, and then transaminitis. And then initial monitoring of her baby was significant for fetal heart rate deceleration, which especially in the setting of severe abdominal pain was concerning for placental abruption. And she was taken for an emergent cesarean section. Her postoperative and postpartum course were complicated by respiratory failure. She previously had no respiratory history. And over 2 or 3 days ended up on 5 to 6 liters of heated high flow nasal cannula and persistent hyperglycemia, blood sugars in the 4 and 500s. On post-op day 2, we collected amylase and lipase, which were significantly elevated. Amylase was about 1,200, lipase about 1,800. And then on post-op day 7, she had a CT scan of her abdomen done that showed necrotizing pancreatitis. And so you can see there in the left column, the initial images of her pancreas with almost entire obliteration of her normal pancreatic tissue, and that abscess measuring about 14 by 4 centimeters. Initially, she was managed with antibiotics and insulin, and she was discharged home on post-op day 11. She did have multiple readmissions for abdominal pain and hyperglycemia. And then a repeat CT scan on post-op day 39, which you can see there on the right, showed persistence of that necrotizing pancreatitis, which at that point, given that it had been more than a month, they said could be either necrotizing pancreatitis or a pseudocyst formation. The measurements were essentially the same. It was about 11 by 6 centimeters. She's currently being followed outpatient by endocrinology, and they're maintaining strict glucose control. She is on insulin, and they're doing serial CT scans to monitor her pancreas. So for the discussion, there are really limited case reports available. On initial literature review. There was only about 2 other case reports of patients who had developed necrotizing pancreatitis as a complication of HELLP syndrome. And there were several theories put forward about how and why this happens. The first is that HELLP syndrome is thought to come about as a abnormality in microvasculature and an abnormal immune response. And that could also be happening in the pancreas and cause microvascular damage that could lead to pancreatic ischemia. The second theory is that an exaggerated immune response could lead to cytokine-induced pancreatic damage. And that's especially interesting in a patient with a history of autoimmune disorder, like this patient who has Hashimoto's. So just take home points for this patient. This is, like I said, this was very rare and unexpected. I think the biggest take home point for us and our team was just to maintain a very broad and wide differential, especially in the setting of lab values that do not make sense for the normal progression postpartum and postoperatively for what we typically see in preeclampsia and HELLP syndrome. That is it.
So was there a specific organism cultured from the necrotic pancreas that you guys found?
Sorry, there was not. They actually did not sample the pancreas. IR did an evaluation and they felt they weren't able to safely take samples from that pancreas. So there was not an organism found. And actually her initial delay, well, not necessarily delay, but her initial respiratory distress, we had explained because she was incidentally found to be positive for human metapneumovirus, which doesn't usually cause significant respiratory distress, but there is kind of a little bit of a confirmation bias at play in this case as well. But there was no specific pathogen identified, and she got 2 days of broad spectrum antibiotics and then a week of more specific antibiotics, and they were discontinued.